Aloha mai kako. Thank you for joining us this afternoon. We're glad that you're here. We can't wait to bring you this final episode of E Ola Mau. We'll get started in about 2 minutes. We want to allow some time for some of our attendees to trickle into the room so that everybody can see the full presentation. Thank you so much for joining us. I see some very familiar names in the attendee list, and welcome. Welcome. We'll be starting in just a moment. Welcome. We've got 3 great guests we're going to be introducing in just a little while. As we get started on episode 6 of E Ola Mau. Mahalo for joining us. Let's see if there's some other folks that are trickling into the room. Some of you have been so loyal, attended every single report back to the community. Mahalo nui. We're glad to see you there. And we'll start in, well, let's start now. Thank you for joining us. Aloha and welcome from Ola Lōkahi, the Native Hawaiian Health Board. My name is Kim Ku'ule Burney. I'm with Ola Lōkahi, and today we will be bringing you episode 6 of E Ola Mau. First, please know that this webinar is being recorded and live streamed across several different platforms. If you have questions, we welcome your questions. Please put them in the Q&A panel at the bottom of your Zoom monitor there. That's where we'd like to get your questions, please. If you are viewing on Facebook, go ahead and put them in the comments section and we will bring them over to Zoom for the panelists to answer. There is an evaluation that will be sent to you directly as soon as you leave this webinar, and then it'll be sent to you again tomorrow. We'll be grateful for your comments and feedback so we know how the presentation is, how you feel about the presentation, and also give Papa and Ola Lōkahi an idea of how we can improve in our programming. So mahalo for that. Some of you know a lot about E Ola Mau. It is, E Ola Mau is the landmark Hawaiian health needs assessment that was initially published in 1985. It provided the data and information needed to make the case to address the disparities among Native Hawaiians through legislation and allocation of resources. The Hawaiian health status has been updated many times since 1985, but our most recent comprehensive assessment, E Ola Mau, came out just before the pandemic began. So while the findings are somewhat recent, the environment has shifted considerably. We will be presenting to you the findings as of 2019, but then we're going to ask the panelists what shifts they see in these 2 different areas since the pandemic. This report to the community series shares the findings and recommendations from each of the chapters and allows the presenting authors to reflect on what might have changed these past 2 years. Episode 6 today highlights 2 separate reports: data governance and healthcare workforce. Our 3 presenters are Emily Makahi, Thomas Chalk, and Kimberly Yamauchi. And my first introduction will be Emily Makahi and the data governance report. Emily is a Kanaka Maoli Wahine practicing in the field of community health for more than 10 years. She's a social worker pursuing a PhD in public health studies at UH, where she's studying Native Hawaiian health through Mana Health. She is Haku Ho'oponopono, having been taught by Lee Keke and Lynette Peglinawan. And she is currently serving as the Deputy Principal Investigator in the Research Department at Waianae Coast Comprehensive Health Center. She continues to work toward helping individuals and communities access appropriate cultural health for their overall well-being. Today, Emily will be presenting the report on data governance. Aloha, Emily. Mahalo nui for joining us.
Aloha kako. Mahalo for having me on behalf of all of the contributing authors of the data governance. I just want to thank Papa Ola Lōkahi for providing the space for us to talk about data governance, which, you know, does have some connotation attached to it from previous allegations of how data has been viewed within our communities. But I want to start off with increased knowing, right? So what do we know about data? So the beginning of our data governance chapter opens with this excerpt from the Kumulipo, right? The opening oli, the Kumulipo, our beloved account of the beginning of our life for our pai'aina, right? Our life sources, creatures, kane, wahine, right? All of this is an illustration that our data sovereignty journey is rooted in traditions of our ike kupuna, right? Through mo'olelo, through oli. The retelling of the story of origin for Kanaka is really important in moving forward because it insists that any Western thoughts and methodologies around the idea of data governance must be set aside in order for us to breathe life into the stories that recall the customary Hawaiian ways of doing. And so the selection of the Kumulipo that our data governance authors chose was really to highlight what was important, not only as a listing of birth into existence, but it was also an observational account of the relationships and knowledge and it leading to specific action or outcomes. So again, like so many of our practices today that we continue to learn or mark as a factor in cultural revitalization or cultural sovereignty, we must not forget that our practice of data stewardship. Right. And so indigenous data sovereignty, indigenous data governance, right? These are terms that we're increasingly hearing and they're being used across communities, data items, right? Through research and policy and in practice. So the indigenous data sovereignty movement has emerged in response to poor data responses, right, in our practices, from conceptualization of data items through the reporting of data about Indigenous people. So Indigenous people have always been data collectors and protectors. And because of this increased knowing, we are becoming more engaged in the idea in response to historical practices of data stewardship, right? Collection, teachings, the use of data, and how to guide good practice moving forward. Next slide, please. Okay, so in today's context, right, what is data sovereignty and why was it added to the E Ola Mau where it was not included in the original reports? So as we gathered together, and I was just reminded that this happened, our beginning meetings in like 2016, over several meetings, each working group would share areas of limitations. And we definitely saw an emerging theme from among the medical group, mental health, nutrition, dental, etc., which had to do with data. So as a collective from various health professions, the creation of the Data Governance Task Force in context to the E Ola Mau chapter was created and a whole chapter dedicated to it. So I will say when we're talking about promising approaches, that's a promising approach that we're actually included as a chapter and not just as limitations or recommendations within each chapter. The Data Governance Task Force states that data sovereignty is openly defined process to regain control of our Indigenous story and acknowledge the significance of Indigenous perspectives on research and data governance. So without meaningful, valid, and timely information regarding Native Hawaiian health, we will not know how Native Hawaiians are progressing, right? Subsequently, we wouldn't know what needs to be done to improve Native Hawaiian health. And therefore, we have added the Data Governance Task Force, not only to address Hawaiian data quality and scope, but also to speak to the issue of ownership and onus. Next, as we began to discuss the influences upon Indigenous health, we see that social determinants of health, colonialism, generational trauma, and institutions and systems contribute to the harm and health of individual communities. So within the context of data sovereignty, these societal level factors not only impact the health of Native Hawaiians, but also influence data quality. Where there is severe mistrust of Western data and the use of it to tell a much different story of our people than our own history of knowledge, right? So what our historical counterpart, the E Ola Mau Report, taught us was that a lack of data was resulted in lack of services. Next, there was this understanding that our history, oh, I'm sorry, yes, thank you. Previous slide, I'm still on increased understanding. Thank you. That our data stewardship practice was absolutely set up for both quantitative and qualitative data, right? So where we saw Western research and academic science lagged in the understanding of sources of data, our cultural practices always included that. And lastly, we looked at the increased emphasis on quantitative data, right, to inform health practices. So there's been an increase in the collection, availability, use, and disaggregation of Native Hawaiian health data. Historically, even when available, data from Native Hawaiians and Pacific people were aggregated together with Asian Americans. So in most health surveys and demographic data, the results from these analyses obscured significant health disparities, so with potential adverse impact on access to healthcare and other resources. Next slide, please. So with our gaps, we identified, despite greater recognition of the importance of quality data and data governance to improve Native Hawaiian health, the task force was only recently formed as this key component to E Ola Mau. But many efforts are increasing with Ola Lōkahi, Hawaii Budget and Policy Center, right? There still seems to be a question of capacity, right? Which I think goes to our next presenter on workforce development, and hopefully can start including health researchers, right? As we discuss health workforce. Another gap that we identified was under previous federal guidelines, right? The Office of Management and Budget, Native Hawaiians were included under a collective category of Asian Americans. So Asian American, Asian or Pacific Islander were persons having origins in Far East, Southeast Asia, Indian subcontinent, Pacific Islands. OMB 1997 standards broke this category apart and established this new category for Native Hawaiian and other Pacific Islanders. So any person having origins in the original people of Hawaii, Guam, Samoa, and other Pacific Islanders. So although progress, we do see that this is a limitation of a broad data category. Next slide, please. So there still remains gaps in the organization and coordination of data-related tools, community engagement, partnership, and common repository of culturally meaningful data. Within the context of data sovereignty, there does not exist one entity that fosters and leads the process of data linking, right, or data sharing across disciplines. So technology we see is really being underutilized to streamline data collection, storage, and sharing. There may be this undercurrent of concern that resources devoted to data and research will actually detract from direct services and other opportunities for Native Hawaiian communities. Next slide, please. But amid all of those gaps, our data governance task force was able to look at, well, what can we do for the near future and then past that, right? I do believe that the stewardship of a culturally focused data governance and sovereignty is increasing. What E Ola Mau started was many examples of large data sets that are being utilized to gain knowledge regarding Native Hawaiian health. And what we're seeing is Native Hawaiian serving organizations that utilize non-quantitative approaches to enhance quantitative methodologies, right? To obtain more culturally meaningful results and information. And thereby, we're advancing cultural wellness, we're advancing holistic health. We're also seeing a utilization of more evaluators for practice and impact purpose versus a base for funding recommendations. So what I mean for that is we're starting to value data to the point that we are hiring our own evaluators and creating our own tools for collection and telling our story based on our practice versus our funder who tells us that we have to. And if there is one thing that we as Kanaka have always been cognizant of is the collective. So increasing partnerships among healthcare providers and organizations to improve quality and shared value of data practices. Next slide, please. And so another promising approach, it's not enough, right, just to advocate for standards on how we are counted, but more for the actual huli, right, of the system when it comes to data. And we see this happening. We see more people taking up space in areas that did not count or even know who we are as Kanaka. So we continue to advocate for efficient ways to place our Native Hawaiian frameworks and our holistic vision of indicators of health so that data practices actually start to look and feel like our practices from before. Next slide. So what did our data task force recommend for impact, right? I don't think it's enough to just recommend data collection methods, but we see that these methods sustain for life course for the individual, right? So where many of our federal and state agencies provide care during a snapshot of our lives, right, then leaves the culmination of that data behind and lacks information. So what do I mean by that? A lot of our healthcare systems or healthcare services are still very siloed in a sense. So children with mental health disorders or disabilities and adult mental health disorders and disabilities, they don't really talk to each other. But we know that children with mental health disabilities become adult with disabilities. So we need to have something in place that kind of looks at the life course data collection. We also think that there's this prime example of how we think it would be a good idea to collect specific data, but how do we ask this question? So even this idea of collecting Kanaka, are you Hawaiian, yes or no? Even that term, right? What does that term hold for us? What does Native Hawaiian term hold for us? And what is truly accepted by our community is how do we collect data, right? Because we know Native Hawaiian, that term itself still holds a lot of colonized ideologies. The data governance task force also should be continued, of course, obviously past the E Ola Mau, right? Not just writing a chapter, but definitely adding to the practice. This mission would be able to fulfill the Native Hawaiian health data needs, including cultural, meaningful conceptualization, collection, storage, security analysis, and then dissemination and sharing. The mission may include addressing the remaining recommendations of this E Ola Mau. Next slide. Perfect. More recommendations is we allow for flexibility and modifications given the unique circumstance for each community or project. So it's continually changing methodology and environment of data governance, but again, it's still being driven by Kanaka and a lot of our service agencies. One essential benefit of data governance and sovereignty is to encourage the rebuilding of indigenous nations and communities to tell our own stories, right, from past and present. So unified understanding of those barriers to data governance generates a comprehensive gathering of researchers to engage in partnerships. And next slide, I believe this is my last slide. So I wanted to end with an olelo no eau that we've actually included in our chapter as well, but it was ko'i kapua kapo'e polohuku ole, right? So those without resources will land at kapua, and we pukui again translate that to without resources, one gets nowhere, right? Culturally meaningful, high quality data are at the heart of improving Native Hawaiian health, right? If we do not have meaningfully defined or methods to collect, analyze, interpret, and use the results of data, we can't evaluate our status or trajectory of Native Hawaiian health, right? So despite the rich Hawaiian history of qualitative data, there remains this fundamental need for Native Hawaiian data governance and sovereignty. So since the 1985 E Ola Mau there has been an increased understanding of this importance of Native Hawaiian data and governance, and understanding that adverse societal factors, right, integration of qualitative data, and then the importance of disaggregating Native Hawaiian data is very much needed. That's all I have to share, but I do want to take a second to just mahalo to all of the contributing authors, which I love is also spans the health workforce field, right? So mahalo to all of them for providing me space to share the story that our task force created.
Thank you so much, Emily. I think it's important. Thank you for initially pointing out that data or data governance wasn't part of the original 1985 E Ola Mau, but it really has taken a prominent role in how we shape healthcare today. Healthcare programs, policy, everything. I really appreciate that. And, you know, my question that I plan to pose to you is really quite an obvious one when it comes to COVID. Today, Hawaii is still the only state in the nation that has disaggregated Native Hawaiian from Pacific Islander data when it comes to infections and even deaths, to the extent where that data is being collected by the providers. And we consider that to be a huge win in the COVID pandemic situation, because it has helped all of us to respond to the communities and tailor programs that can address all that. Can you think about some other shifts, either in the gaps or understand how we understand data in light of the pandemic? And then, of course, any new recommendations that you might add on?
I think COVID really did highlight that idea of, without that data, we really don't know where we're putting our resources. And I will say that I think the other thing that I want to highlight is that data isn't just deficit based. I think that's how we've looked at it before, right? Oh, Native Hawaiians are this. Oh, they are missing this, or they're not, you know, they're not up to standard, et cetera, et cetera. But really, I think we want to be able to also use data as to where our efforts have actually succeeded and probably have increased outcomes, like health outcomes, without Western methodologies or Western ways of thinking. And so I think for us, data is really important to also highlight the strengths of our community, as well as the strengths of our practices that are already in place. And we just have this very limited idea, like even the word data, right? It's not the best 4-letter word either. And so when we think about data, we definitely think about those surveys we fill out and things like that. But data, how we govern it, I think can be very powerful. And that's why I think our group wanted to start with the kumulipo, in the sense of we were already doing this. We were already data stewards for so many things that led to outcomes, right? So it didn't just lead to collecting data for a beautiful workbook, right? It really led to action. And that's what I think we wanted to highlight, was that we definitely have the practices in place. And I think COVID just kind of reinforced that idea that there really needs to be this somewhat central organizer of those ideas, and really supported by a lot of the health workforce department as well, right? So whether it's individual, private, or state or federal, having that one trusted source to really not necessarily gatekeep, but I think protect the data.
Which is what the kumulipo is. It's not the gatekeeper, but it is the repository of our traditional data, our traditional knowledge. So I really appreciate that. I don't see any questions right now, but I hope that you'll stay with us, because we may have, as we move through the next report, we may have some additional questions that people in the audience are thinking of. You do have one, mahalo nunui, a kumu, Emily. So I'm guessing Alicia might be one of your haumana. Mahalo nui, and mahalo for this presentation. If you'll stand by, Emily, we'll bring you back up later to answer questions from the general audience. Thank you so very much. Next, I would like to bring up our next two presenters. The second report that will be report to the community that will be presented today is on the healthcare workforce in Native Hawaiian community, and we have two presenters. Kimberly Yamauchi is the program assistant, faculty lead on student recruitment, advising, and engagement at E Ola post-baccalaureate program at the Johnny Burns School of Medicine. And she assists with the Native Hawaiian student pathway efforts with the Native Hawaiian Center of Excellence at the medical school. She brings with her more than 15 years of experience in recruitment and retention of underserved and indigenous students in Hawaii and throughout the Pacific. Born in Beilao, raised in Saipan in the Northern Marianas and California, Kim is of Chamorro, Carolinian, and Caucasian descent. She received her bachelor's in communication and a master's in public administration from the University of Hawaii at Manoa. Welcome, Kim. Your co-presenter, I want to introduce Thomas Chuck. Born and raised on Oahu, growing up mostly in Kaimuki, 1991 graduate of the Kamehameha schools. Thomas spent 2 years in Sao Paulo, Brazil as a missionary, and then returned to college, went to college at Brigham Young University in Provo. He has a bachelor's in media arts studies and an MBA in organizational behavior. Thomas is a husband, celebrating 25 years to marriage to Rebecca this summer, 5 keiki, and a couple of mo'opuna with one more on the way this summer. Currently transitioning away from being a stay-at-home dad so mom can pursue a master's degree in, this is fascinating, choral conducting. I don't know anybody who has a degree there, so I hope to meet Rebecca someday. Welcome, Kimberly. Welcome, Thomas. We look forward to hearing more about these findings and gaps and recommendations for the Native Hawaiian healthcare workforce.
Hello, Kim. I just want to piggyback a little bit on Emily's presentation. As she was presenting, I kept feeling like, man, there's so many parallels and so many echoes in the stuff that the workforce development group came up with. So another mahalo to Emily for her excellent presentation. I'm gonna probably be speaking more of the time than Kim, but Kim has a lot of really great information to share. So I'm gonna try to get through everything as fast as I can. So I kind of wanted to start my segment with a personal story, with an anecdote. Just recently, we moved my elderly mother into our home, and we're super grateful that we have that ability. We know that not many people have that ability. We have the space for her, and it's been overall a positive thing. Just a little experience that happened just 2 days ago. I was reaching out to a local insurance carrier that is a channel for my mom's Medicaid, right? Because she qualifies for Medicaid, and so we're looking into maybe getting an eval for her for possible continued home health for her while she's here with us. And I found out from the operator, the person on the phone, that it's going to be at least 3 to 4 weeks before they can send someone out for an eval. And I asked, oh, how come? And the lady said, well, there's only 2 people that can do that in the entire state. And those 2 people cover the entire state to do these kind of evals for home health. So I think that it just hit home. When I had that experience, I'm like, I got to share that with the group today, because it kind of highlights the challenge that we have here in Hawaii with just in general the healthcare workforce that we are kind of running out. we're starting to see the attrition rates, and it's it is a real thing that's impacting everyone, right? So why me? I did ask Tertia a little bit. Okay, you sure you want me to present on this? Okay, so I wanted to give a little bit of context on why me. So at the time in 2016, I was an employee at Kamehameha, working on a project around lining up work-based learning opportunities for beneficiaries of Keali Pawahi. Sorry, and I was asked to participate in the E Ola Mau project. Obviously, well, maybe not obviously, I'm no longer an employee at Kamehameha. I'm not an expert on workforce development, and I'm not in the healthcare field. However, as was stated, I am a Native Hawaiian. I'm a husband to a mother of Native Hawaiian children, a father, a son, a brother, and a citizen in the community. So being born and raised there, and was mentioned, a graduate of Kamehameha, recently moving back to Hawaii with my family after 2 decades away, I wanted to frame my mana'o today in that context, that I may not be an expert per se, or a practitioner per se, but I'm a member of the community who has some thoughts. And I was lucky and blessed to be able to participate in the workforce development team, the workforce development committee, in the formulation of our chapter. So I may need Tertia or Kim to verify this, but similar to the data governance, in the original E Ola Mau, there was no workforce development. I believe it was broken out into all the other chapters as well.
That's correct. And
okay.
in fact, we were hoping, there was one initial thought as we developed the E Ola Mau that every report would have recommendations for policy, would have recommendations for resources and funding, and would have recommendations around the healthcare workforce. But then the workforce became, there are so many partners in the workforce development that it became a report all on its own. So here you go. This is you.
Right. No, yeah. So, okay. So I remember correctly then. So again, very similar to the data governance, with as we move forward, the decades since the original, we see that workforce development kind of needed to be broken out into its own chapter. I want to right up front acknowledge Auntie Stephanie Bell. Pretty much everything you see in a chapter and all of these bullet points that you're going to see in the presentation, she did most of the heavy lifting, pulling together, wrangling the cats, right? Herding the cats, all these different ideas that were shared amongst the committee over the years. So I don't think Auntie Stephanie is on with us, but I just wanted to shout out Auntie Stephanie for all the work that she did, kind of bringing this all together into some kind of a cohesive thing that makes sense. When I was like I said, I'm not an expert. I don't have anything workforce development related, but I do have some knowledge that I think provides some perspective on this. And as I shared with you, I currently am kind of in the middle of trying to figure out how to care for my aging mother, which, is another big piece of this puzzle of healthcare, of Native Hawaiian healthcare moving forward. So clearly there is a need. I was lucky enough to spend a few months working with Dr. Kelly Withy, who is from AHEC at JABSOM. And I was supposed to be what was called a physician's recruiter for the entire, for all of Hawaii. And, was made aware of, how real the numbers are in Hawaii in terms of attrition, just for the MDs, just for, physicians here in Hawaii. Just as a funny, maybe not so funny side note, the day I was hired was March 13th, 2020. If you remember your history, what happened on March 15th, 2020, basically the whole world shut down. And then my job kind of changed, and yeah, it was kind of interesting. But I did get some knowledge of what at least the numbers for in general, not specific to Native Hawaiian healthcare practitioners, but in general, what was going on with the doctors in Hawaii and that attrition there. You'll see, I'm not gonna spend too much time on the slides. Sorry, I know you guys prepared it. Thank you, Tersha and Kim. But I told Tersha that I'm gonna kind of focus on the stuff that I remember being the squeakiest wheels from our conversations with the workforce development. There are three, and one kind of was already talked about by Emily, which is data. And specific to workforce development, we need disaggregated data for Native Hawaiians in the healthcare workforce. We had Phyllis, I think her last name was Dayao, from the Department of Labor on our team. And I may need verification from Kim and Tersha on this, but I believe when we talked to Phyllis about this, she mentioned to us that the only way to get the disaggregated data, I think it needs some kind of law to be passed, or it needs to be brought before, the legislature or something like that, to be able to break out Native Hawaiians in the healthcare, in healthcare fields. And similar to what was stated before by Emily, we cannot know what's actually working specific to Native Hawaiians if we can't measure. If we don't have data to start from, like, how do we know what's working? How do we know things are moving forward? The second big umbrella thing that was a squeaky wheel for us was incentives. I call it incentives. And on one hand, it's like the financial economic incentives for getting more of our Native Hawaiians into the healthcare workforce, and again, in general, getting people to choose to stay in Hawaii, to either come to Hawaii or stay in Hawaii in the healthcare workforce. And then there's other types of incentives that we talked about as well. But we talked about the high cost of living in Hawaii and how do we attract and keep healthcare professionals in that context. We talked a little bit about a mindset shift. This is kind of the non-financial, non-economic incentives that we could have. We talked, I think Emily also kind of alluded to this a little bit, kind of how Native Hawaiians see themselves in the context of all of this stuff, and kind of maybe looking at maybe shifting our mindsets about healthcare in general and how that whole system works. We asked the question, why would a young Native Hawaiian with the capability to enter healthcare, A, choose to stay in that field, B, choose to stay in Hawaii, C, choose to include some of the indigenous practices and training? Because we also talked about that, right? The three, even the three pillars of, well, at least what we hear about all the time, Ho'oponopono, Lomi Lomi, and La'au Lapa'au, right? And then we talked a little bit also about insurances, like, the system that we're in now, there's an insurance, company. Are they going to pay the practitioner for the person who goes to them for Lomi Lomi or for Ho'oponopono or for La'au? So those are some of the issues around incentives that we had talked about. And then the last kind of big umbrella idea we had talked about was training. And this is kind of where I think I can transition more to Kim, but some of the issues that we talked about were just the availability cost of, whether it's the Western modalities of healthcare, and I think Kim is going to share with us some really great model for how we can approach that. And then also indigenous practices, right? Like those three, that Ho'oponopono, La'au Lapa'au, and Lomi Lomi. What training is available? How do we access that? How do we motivate or incentivize our OPO that are coming up to look at those as viable careers or whatever, all those kind of things. And then we also talked about in regards to training for those things like Ho'oponopono, La'au Lapa'au, Lomi Lomi, who gets to claim they are a legitimate practitioner, right? Oh, my uncle taught me, or who's your uncle? Oh, that kind of stuff. And in the current context, that might not fly. But perhaps, again, going back to that mindset as a potential promising approach moving forward, we might be able to shift some of that mindset about, who gets to call themselves a kumu, who gets to call themselves a haku ho'oponopono, who gets to do that, and who gets to determine, who can carry that title moving forward. Or maybe that's not even the approach that we should be taking because, for whatever reason. So, because it's, more of a Western, I think Emily used the word, a colonized mentality. So, these are some of the questions that we wrestled with as we were going through this. I think that's kind of the bulk of what I wanted to share. I want to kind of hand it over to Kim so that she can share with you guys what they're doing at E Ola, and what I would like to point at as a really cool example and model that I think does a pretty good job of answering some of these questions the best way that they can within the context of where we are right now. So I'm gonna kind of hand it over to Kim. I think the slide is the next slide, I believe. Yeah, okay. All you, Kim.
Aloha, hawhares, and tiro. I am Kim Yamauchi, and I am the program assistant at the Department of Native Hawaiian Health. I'm a faculty member at the E Ola Post-Baccalaureate program, and as my bio said, Native Hawaiian Center of Excellence. Thank you so much for introducing me, Thomas, and for all of the work that you have done. I see in the audience we have Dr. Martina Kamaka, who's also a faculty member within our department, and she does a lot of the cultural components within the medical school, which is really amazing as well. But Department of Native Hawaiian Health is here at the Johnny Burns School of Medicine, and we are the only indigenous serving department within a US accredited medical school, which I think is really amazing. The programs I wanted to show and highlight today, our pathway programs would start with the Native Hawaiian Center of Excellence. And over here it says, what we really want to do is we want to help Native Hawaiian students that are interested in medicine become stronger applicants. We do that through several workshops and a lot of mentoring with a lot of our faculty here at JABSOM. Our pipeline programs for Native Hawaiian students don't stop when they enter medical school. We also have different programs within the medical school. And I know what Kim had asked me earlier is, what do you do to get out to the community? So our Native Hawaiian Pathways to Medicine, like I said, it improves the competitive of Native Hawaiian students applying to medical school. We work with social work students as well and do an interdisciplinary program. And they do a lot of culture-based in that Native Hawaiian interdisciplinary health program. Then while they are in medical school, when they get in, we have different community health electives. I listed 2, but Dr. Kamaka also has another one. And I listed this 2 because this one we really do go to the high schools in these 2. So the Nanakuli Intermediate High School and High School, as well as Waianae High. And what our faculty will do with these programs is take medical schools to the population, into the community, so that the students in those environments can learn from the med students and see that, wow, I can be a doctor too. Look at them. I can talk to them. And, it's somebody who looks like me and can talk to me, and hopefully I can do that someday. So they've been some really great programs along with the Native Hawaiian Health Past, Present, and Future. We've also started a mentorship program with DNHH faculty with Native Hawaiian physicians, and I apologize for the spelling. Oh, no, we got it. The Ahahui o Nakaka. So we work really closely with them with NHUE so that our med students that are Native Hawaiian can have somebody that they can talk to. They can ask questions and they can mentor them while they are on their pathway to medical school, which I thought was really, really special and unique about Native Hawaiian Center of Excellence. This photo here is a kihei ceremony. So this is one way that we do bring in culture. This was last year's graduating class, the class of 2021. We had 12 Native Hawaiian students that graduated from medical school and are now completing their first year of residency. So I thought this was a great picture to show that what we're doing does have an impact, and I'm hoping that we can continue this. So that is our program for Native Hawaiian Center of Excellence. And on the next slide, I will talk about E Ola. This is another pathway. And E Ola is a 12-month post-baccalaureate program for disadvantaged students. And what we do is we help strengthen their basic sciences. And upon successful completion of our program, students matriculate into JABSOM as a first-year med student. So we take 12 students, and the med school will hold 12 spots for those 12 students if they complete our program. It is extremely rigorous, but it does prepare our students for medical school. So first year of medical school is pretty easy for them, they say, at least for the first 6-7 months of med school. And one of the things that we have done during, with COVID is, in the past, our students had 6 conferences required of them. So we're very hands-on. We've actually talked to our students and noticed that they really needed more support. So we've increased our support for our students by having more one-on-one check-ins with myself and our learning specialists to see how they are doing, not only educationally, but mentally and with everything else in their life, with all the other support and things that were happening. The beginning of COVID, a lot of our students had to translate for their parents or help them get, other types of support. So we did assist and work with the students a lot, because there was a lot of stress other than the education portion. Another thing that the students that were in medical school said, the Imiho Ola students, is they really wanted more mentoring. So we started more mentoring for our Imiho Ola students that are in medical school. So we followed the model that NHCOE did, and we provided more opportunities for our students to mentor with other alumni that have completed the program, with each other, with faculty. And I think that touch has been very helpful through the pandemic. This photo is of our graduating class from last year. We had 7 students complete the program last year, and they are completing their first year of medical school. On the next slide, we have data, because everybody always asks about data. So Dr. Malia Purdy is one of our faculty members at NHCOE. She also teaches humanities and medicine at Imiho Ola, and she did a study, and she looked at Imiho Ola from 1996 to 2016 and looked at data. So she found that Imiho Ola, we had 30% of our students that were in the program were Native Hawaiian, 27% Filipino, and 10% Pacific Islander. So just seeing that number is really amazing, because like we were talking about data governance, being able to pull that out is just so powerful to see that so many of the Native Hawaiian students that went through the program, were this, and then that's an opportunity to hopefully get them into medical school. Large number of our students were male at the time. 57% of the students that entered the program were male and 43 female. We have been seeing a shift. This current class was the first class that we had 12 wahine. We had 12 females in the program at the beginning of the year. 95% of the students that enter the program come from Hawaii and the Pacific Basin. So it's one of the requirements for Imiho Ola is they have to have ties to Hawaii and the US affiliate Pacific. And during this time, we had about an 80% completion rate. So if you have any questions on Imiho Ola or the Native Hawaiian Center of Excellence, please type it in the chat. And I'm going to pass it back over to Thomas to finish up our presentation.
Bring it on home. So the reason I'm so glad that Kim jumped on with me, because she actually has an example to share, which I don't have. And I wanted to point out the 3 kind of big areas that we had that I remember from our conversations was data. And you can see she has the data broken out where, 30% Native Hawaiian, that last slide that she had. The training, obviously, at JABSOM and Imiho Ola and all those kind of things. Even though it's, obviously from a Western, let's just say it's more Western modality of healthcare. It's a model we can look at least to see, okay, how do we, is it working? And I think those 12 Native Hawaiian doctors that are doing their residency this year is an example of it working. And then the financial aspect, Kim didn't really, I don't know that you shared that too much, but Kim and I kind of in our prep for this, we talked a lot about, on the front end at least, there's a lot of grants and scholarships and just stuff that's available for people who want to pursue healthcare in Hawaii. And at least on the front end, it makes a big difference, you know, if you don't have to worry so much about, you know, how much it costs to go to med school or those kinds of things. You know, and we recognize that on the back end, right? Once they PAL school, like they want to start practicing, those are some of the challenges that we still need to kind of look at and maybe fiddle with. But it is promising to note that on the front end, these programs are helping students financially. Kim, did you want to speak to that a little bit?
Well, during our conversation, we talked about the cost of medical school, and being a resident student here in Hawaii, it's under 37,000. So I was sharing that medical school is cheaper than my daughter going to undergraduate in the States. So the students, so, you know, here it is expensive. There's a lot of fees, there's a lot of things, but it is more reasonably priced than going to a school somewhere else in a different state. Imi Ho'ola, we've been blessed that our students do get support from different programs. We've worked really closely with the Queen's Healthcare System, and they've helped our students while they're in the program. And JABSOM and EMI, we've been working really hard to get scholarships for our students. So JABSOM students, a lot of them will get scholarships for medical school. And then the Queen's Health Systems has helped us provide scholarships for some of our students to pay for their medical school, at least the resident tuition. And we've had private donors also help our students. Imi Ho'ola students are not qualified for federal financial aid while they're in the program because it's a non-degree granting program. So we are really, really grateful for all the support that we do get for our students because it is such a rigorous program.
Yeah.
But no, it's been great. Thank you.
No, yeah, I just wanted to kind of highlight that because I think that's part of the solution, I think, moving forward. So just kind of, I think we have 2 more slides. As you can see on this first slide, the first 3 bullets kind of are, again, the things that I remember. Like, so again, that maintaining a thriving workforce to address Native Hawaiian healthcare needs. We talked about that there is a need, whether it's Western, whether it's, you know, more indigenous practices. There's a need for just in general healthcare practitioners here in Hawaii. Develop and maintain comprehensive centralized data collection. Yeah, we just need better data to know how we're doing, just in specific to Native Hawaiians in the healthcare field. And then support existing effective education and training programs and develop and sustain new ones that will create a thriving workforce in Native Hawaiian health. Jackie posted in the chat, you know, the frustration that, you know, it's kind of like this reinventing the wheel of, you know, the idea of, you know, we have training, we have, you know, Papa Ola Lōkahi has done a great job over the years of kind of gathering our kupuna and our kumu and, you know, the people who are the experts in this and creating these kinds of paths to certification or training or whatever you want to call it. And I wanted to acknowledge her comment and say, you know, I didn't intend to say that that's an ongoing problem, but that was something that we as a workforce development task force, we identified as a question that would be had and would need to be addressed moving forward. I think the rest of the bullet points, if you want to go to the next slide, I think they kind of cover some of the things that we've already talked about. Culturally relevant. We talked about the financial security, quality of life issue. Maybe not directly, but yeah. And then this last bullet point, yeah, I think if we can pull together that, I think, you know, my experience with Dr. Withy at AHEC, just as a kind of parting remark here, showed me that there are a lot of folks here in Hawaii who are aware and are paying very close attention to this issue of workforce development in healthcare in Hawaii. I don't know that everyone's connected as well as we could be or should be, and I you know, I believe Papa Ola Lōkahi would be a great you know, torchbearer for that effort, moving forward. Yeah. So other than that, yeah. Okay. Thank you for, like I said, Stephanie Bell, and myself. There was a lot of really good people that participated in this, but anyway, I'm gonna turn the time back over to Kim, Bernie, and yeah, we'll go
Thank
from
you
there.
so
Mahalo.
much. Thank you, Thomas, for your personal insight and making them really relevant to the recommendations here. Kimberly, for that hard data. I have to call you Kimberly because I'll just get too confused by saying, now over to you, Kim. This is Kim. Yeah, so can we bring Emily back in here also? You know what I really appreciated, and I didn't see this in any of the recommendations, but that last recommendation said, now let's assemble a hui to enforce these recommendations. And of course, that's implied. We don't want to just, develop recommendations for people to put them on the shelf. We actually want to forward them to all the appropriate entities, and who is going to be, what body will help to move them along. And I really love that that is actually articulated in the healthcare workforce report, because I don't recall seeing it in some of the other ones. Mahalo, Jackie from Halava. You are one of our, she's a member of the Papa Ola Lōkahi fan club. So mahalo nui for that. And West Oahu UH, that's right. Native Hawaiian Indigenous Health, where Dr. Kau'i Baumhofer Merritt is on faculty there. And so you must be very proud, Jackie. Mahalo for tuning in. I don't see a whole lot of questions here. Any last comments? Not last comments, but this was all, again, it was developed prior to 2019. Now things have shifted a little bit because of the last 2 years in the pandemic. What things would you change a little bit, or would you add into your respective reports as a result of what the pandemic has uncovered or has shown us new?
I'll chime in on something. My friend Momi Akana at Keikioka Aina, we were talking story one time, and in regards to this healthcare issue, she posed a question to me, which I think is part of kind of maybe what we need to think about going forward. Is she kind of posed a question like this: didn't our kupuna basically have like a la'au in their family unit, in their ohana? Didn't they practice ho'oponopono on the regular? Like, they didn't have like necessarily a haku ho'oponopono that was always doing the practice of ho'oponopono with them. Like, each family kind of had their practitioner or whatever. And she kind of posed that question, like, what if we reimagine healthcare in Hawaii so that each family unit, each ohana had a practitioner, and it wasn't necessarily something that you got paid for or it was a career, but it was just something that every family unit had that. So I wanted to kind of just drop that in there, just as part of the idea of just kind of the shifting mindset that maybe is part of the solution moving forward.
Especially if you're at home, right? If you are living in a bubble, which I think many of us have tried to do throughout the pandemic, then who is the healer in your home? Who is that provider in your bubble? I like that. Great, thank you. We're going to wrap it up in just a couple of minutes. Kim and Emily, any closing thoughts about your overall report, or how you might see things slightly differently as a result of the pandemic?
Yeah, I think just to tie in, and then to hopefully tie in our chapter, was this idea also that in defining what it is that our healthcare workforce looks like, what our healthcare needs are. So you folks talked a lot about, kauka and physicians. And I think, there is a question in the sense of how does that also look for other professions? I think, like we said, really understanding what health looks like from a Kanaka standpoint as well, right? That it could include kumuhula, it could include our alohe, it could include so many more things, but we're still really limited in how our systems are defining it for us. So again, I think workforce and data governance to come in together was a really smart idea in that sense of how do we define these things? How are we as a lahui really putting value again on what data we want to begin to collect so that we can move forward. And I think that idea also of redefining, I think, like you said, I think what has been done in the past 2 years, which during the pandemic, 2 years feels like 20 sometimes, but I think it really shows that we have capacity to do this. What we need now is that for all of our task force and all of our individuals to then advocate for actual system change, right? So that we can, that whole point of, that's not even a question that it should be put on insurance coverage at this point, right? Or
Right. Good point.
that we're building that Kanaka, like a Native Hawaiian Health Scholarship Program has done an amazing job, but also expanding scholars other than just kauka and social workers. And
Yep.
we just need to continue, I think, to expand and really push the boundary where I think we've been kind of nervous to do so in the past.
Absolutely. And then we do have a question in the panel here that addresses the health professions that are not traditionally funded by scholarship programs. Catherine asks, are there efforts looking at supporting and expanding other healthcare careers, such as speech and language, occupational therapy, physical therapy, nursing, public health, to impact the health of Native Hawaiian communities? Yeah, good
I
question.
can answer a little bit about that. I know that Emily, you probably know this, the social work, there is a lot of, they do support a lot of Native Hawaiian students, and they have a lot of programs to help Native Hawaiian students, as well as public health. They have an indigenous track, Native Hawaiian and indigenous track. I'm not really 100% sure about speech path, OT or PT, but I know that there's a lot that people are trying to do, and a lot of our faculty that work here at JABSM really do try to work with the other departments as well and do a lot of collaboration, if not specifically for Native Hawaiian students, but in the communities as well, like getting research or getting students to go out into the communities and hopefully serving the communities. And then eventually we'll be growing our healers that way. I hope that answered that question.
I think that's a good question. And another aspect to this, and I don't know if we have the answers, but there isn't actually a physical therapy program in Hawaii. There's not actually a dental school in Hawaii. We do have speech and language, and we have occupational aid, but there's not actually an OT program in Hawaii. So that's a whole nother ball of wax, if you will. Thank you, Catherine, for your question. I want to make sure I get everybody. The Native Hawaiian Learning Program that used to fund Native Hawaiian social work students. Too bad that has closed. And then here's a question. Does anybody know of the fiscal arrangement made between ADAD, which is at the Department of Health, and private insurance companies and Waimanalo Health Center? Well, I think we need to ask Waimanalo Health Center or Dr. Jared Euro about that. And we can find out more about that from Ola Lōkahi's side as well. So thank you, smart people. Kimberly Yamauchi, Thomas Chalk, Emily Makahi, mahalo nui for presenting the findings and recommendations from these 2 reports, data governance and developing a healthcare workforce for Native Hawaiians. I'm sorry we don't have more time to talk with you, but we're really grateful, and we want to mahalo all of our panelists for joining us today. We mahalo the audience for tuning in and for asking your questions and sharing your comments. On the back end, we want to mahalo all of our tech support. We have Keabe and Kamuela and Lisa, and Tertia Ku is the kahu of the E Ola Mau project at Ola Lōkahi if you have additional questions. Mahalo to our cross-post partners, several of the Native Hawaiian healthcare systems, the Native Hawaiian Center of Excellence, Ahahui Ona Kauka. And we don't even have a closing slide because this is episode 6, the last presentation in our E Ola Mau series to you all. Please stay tuned. We're going to be updating this over the next year and a half, and we're going to be seeking your kokua to help us update the next assessment of Native Hawaiian health and well-being. Mahalo nui to you all. Have a great day. Have a great week. Aloha and E Ola Mau. Jackie, we love you too. Thank you for all your comments. Yes, there will be a recording available. Amy, aloha nui in Manoa. We also have it on Facebook as well.
Thank you guys so much for this.
Oh, thank you, Kimberly, so much. Thomas, you're awesome. And Emily, of course.
I was
Emily,
shoveling it a
Dr.
little bit there.
Emily, I think you would love to talk to Dr. Martina Kamaka and what she's trying to do to remove the Native Hawaiian numbers in AMCAS and medical school, because it's all combined. So I think you would love that.
Oh, that would be awesome, actually.
Yeah, she's doing some amazing work, really trying to get the numbers of Native Hawaiian students that are applying and attending medical schools. Yeah.
Wow. Okay. Yeah.
Yeah.
Yeah. Data is just one of those things that I think